I'd like to talk to you about the incidence and causes of early onset flexion and extension space tibiofemoral instability after calipered kinematically aligned TKA. I'm going to share the observations of 1,540 calipered kinematically aligned TKA I performed from 2017 through 2019, and they will provide the background for the discussion and the interpretations. So if you look at this plot with the number of TKAs performed per year in 2017, 18, and 19, as you'll see, I averaged over 500 of these per year. In 2017, 429 were performed with retention of the PCL and a CR insert, 257 in 2018, and now 517 in 2019. Now, during that time, we transitioned and excised the PCL and used a CS insert in the latter third of 2017, about half the knees in 2018, and very few in 2019. And so it is this group here in 2018 where we used a lot of total knees with excision of the PCL. So if we look at this time period, we had 4 revisions for early onset tibiofemoral instability. You can see the x-axis here has 0, 1, and 2. That's the number of revisions per year. And we had one in 2018 where we had a tibial component revision from an extension space tibiofemoral instability. And then we had one in 2017 and 19 with full revision for flexion space tibiofemoral instability. And then we had in 2018 a revision with a thicker insert. So we had a 1% incidence, or 3 out of 327, of early tibiofemoral instability in those patients with excision of the PCL, and we had none, a 0% incidence among those with retention of PCL. So it looks like, at least in this limited experience of 1,500 knees or so, that excising the PCL increases the incidence of tibiofemoral instability. Now, the excision of the PCL creates an unpredictable and variable increase in flexion space laxity, and this was something we didn't really have a hand on. We're indebted to this paper looking at posterior cruciate ligament resection, total knee arthroplasty, and the effect of the flexion extension. We like to call it a space for the whole space, but each compartment is a gap. And this was just published in 2019, so it's relatively new information. If you look at the plot, the lateral flexion gap and medial flexion gap on the x-axis, and the change in laxity from the native knee in millimeters on the y-axis, you can see that the mean laxity increase in the lateral flexion gap is about 3 millimeters, but the maximum can be as much as 7. And the mean increase in the medial flexion gap is 2 millimeters, so it's less increased medial, increases the trapezoidal gap when you cut the PCL, and goes up to 4 on the medial side. So the lateral side certainly opens more than the medial side, but the amount of laxity increase can be quite large, up to 7 laterally and 4 medially. So you have to be able to adjust for this wide range of change in the flexion space laxity when the PCL is excised. And schematically, this is the way it looks. So the native knee lateral, if you had your 2 cuts, you'd have this sort of trapezoidal gap in 90 degrees of flexion. But then the mean laxity increase will make this gap bigger, 3 millimeters greater laterally and 2 medially. And look what happens with the maximum laxity increase. You have a huge gap increase in flexion, but not an extension. And so if you have a mean laxity increase, a little on the smaller side, a reduction of tibial slope might be able to compensate for a mean increase in flexion space laxity. However, when you have the maximum increase, you're likely going to need more implant constraint. And if you don't have that at the time, you can get yourself in trouble, which is what happened to me. And so you need more constraint to compensate for the maximum increase in flexion space laxity. So 3 total knee arthroplasties with excision of the PCL were revised for early onset flexion space laxity. One was early. We just didn't have revision instrumentation, and I didn't think of reducing the slope in this patient, and we revised that knee with more constraint. And then we had another one that about 4 months out got unstable. We're not sure whether or not there was an MCL injury, but regardless, because of that laxity medial, we had to use a hinge. And then we had another one, you can see here, excision of the PCL led to increased flexion gap laxity, and we revised it with a thicker insert. And if you look, You can see that the tibia is moving posterior, and we did not compensate adequately in any of these cases for the increase in flexion space laxity at the time of primary total knee arthroplasty. One knee revised for early onset extension space tibiofemoral instability, and this patient complained of valgus alignment with a lateral weight shift, meaning the weight shifted the medial knee. When the knee moved medial and the weight shifted to the lateral aspect of her foot, she got into more laxity. And when we looked at her resections on the tibia, the femoral resections were done kinematically correct, but we undercorrected on the tibial side, had a 90-degree cut instead of 87. This led to a hip knee ankle angle of 174 versus 177 on the normal side, and we revised the tibial component and increased the varus cut in the tibia, and we obtained a symmetric hip knee